Firstly, I'm really thankful to PSIM always inviting me to have talk in the conferences. It's really hard to see so many people at this time. I do Aspirin session frequently in meetings and hardly found 10, 15 people at 8:30 or 8:45. So it's starting with a success. So let's start with the topic. This is just an introduction to my Facebook and YouTube channel. You can find a lot of academic and public awareness video on these channels. Aspirin, wonder drug in preventing cardiovascular events. As Nabil said, that this drug is used for decades, and we all have authentic knowledge about its use in secondary prevention, and still a class 1 indication in it. But some recent trials have created controversies about its use in primary prevention. So it's a very pertinent question for us to have in front of a patient, whether this patient needs aspirin as a primary preventive strategy or not. And we'll try to answer it starting with this brief talk and having comments of the experts to get some guidance who to offer aspirin in primary prevention. What I do, I'll try to cover the rationale of using antiplatelets, assessment of CVD and bleeding risk, looking at the present evidence and indication, and lastly, we'll come to this conclusion, who to receive aspirin in primary prevention. That's very important to understand when we are considering aspirin in primary prevention, that this cardiovascular disease starts as a subclinical plaque. That's very important to understand, because at this stage, we really don't know which of the patient we are considering as primary prevention. Maybe he's actually a patient of secondary prevention, because he may be harboring the disease. And since there is no event, that's why we are considering him as a case of primary prevention. And at that subclinical state, it's all risk assessment, how to assess the risk of your patient, and then weigh the risk and benefit of means by risk of bleeding and benefit of aspirin in this particular patient, and then decide which of your patient really needs aspirin to get benefit of aspirin without harming or causing adverse bleeding effects. So that clearly shows that your disease divides into two phases, atherosclerosis and atherothrombosis. We usually found our patient when he got atherothrombosis and events. And we don't know any of our patient who's harboring atherosclerotic PET. We are considering him to be in a phase of primary prevention, but he may be in a phase of secondary prevention. At that moment, maybe having disease, but without event. That's very important to understand. And we know that whenever the plaque ruptures, platelets have the key role in causing events, thrombus formation, and leading to these all critical events, ischemic stroke, TIAs, MI, unstable angina, and critical limb ischemia. Mechanism of action, we all know. I try to skip that. COX-1 inhibitor leading to decreased formation of and prostacyclin, prevent vasoconstriction, thrombus formation. And its clinical use is, as I already told, is class 1 indication in stable IHD, non-ST, STEMI, and peri-PCI stenting lifelong. This is the area we need to decide which of our patients need aspirin in this phase of the disease. Now, how to decide aspirin use in primary prevention? First, we have to take care of this misconception, can we prevent IHD with aspirin? No, we can't. Aspirin is just to prevent thrombotic event and really lead to decrease the consequence of that thrombotic event, because aspirin has no role in atherosclerosis. It's atherosclerosis, when it leads to atherothrombotic event, your aspirin in system prevents you from having grief consequences of that plaque rupture. That's very important to understand. So no, we can't prevent IHD, which is atherosclerosis, but can reduce atherothrombotic events with aspirin. So this is the key to understand, to pick a patient who may be at high risk of having atherosclerosis, and then keep this patient on aspirin to prevent atherothrombotic events. That's the whole rationale of using aspirin. Now, since we have a lot of studies showing that in low-risk patient, if you give aspirin, you may have harm more as compared to benefit. So that's why you have to integrate benefits and harm. And how to do that? And that's the key which I'm constantly repeating. The benefit of aspirins are related to underlying risk, but harms are independent of risk. That's why in high risk CVD population, benefit exceeds harm. And in low to medium risk, harm exceeds benefit. So it's all depend of weighing your patient's benefit and harm and deciding which of your patient need aspirin. Now the things which really constitutes low, medium and high risk for both bleeding as well as atherosclerotic events. These are the features which you have to look for a high bleeding status. History of previous GI bleeds, age greater than 70, thrombocytopenia, coagulopathies, CKD, concurrent use of other anticoagulants or NSAIDs, already on low dose as pooled cohort, race, sex specific, and this is the risk calculator for atherosclerotic risk. And in this risk calculator, which is predominantly based on the data which is coming from the West, where age makes a major difference in risk. A 40 years and a 60 years will make a lot of difference in risk status. And what we are seeing in our population, even MIs at the age of 35, 30 years, which aren't considered even a risk for atherosclerosis in West. So it's very difficult to really weigh our risk as compared to the Western data. That is again a very important point. And these all youngs are very low risk for bleeding. And we are constantly seeing the major bulk. We see at NICVD almost 40 to 70 or sometimes even more than 100 MIs a day if you ST elevation and non-ST elevation altogether. And 70% of these patients are less than 45, around 35 to 45 years, mostly young people. So that's again very important to understand how to really apply these all Western data to our population. Risk level less than 7, that is according to this calculator. If you put all these variables in this calculator, you found 10-year risk of having atherosclerotic cardiovascular disease. And if this risk is less than 7.5%, it's low to moderate. Moderate is 7.5 to 20. And if you're greater than 20%, you are at high risk of having atherosclerotic event in next 10 years. Now you have some additional modality to pick your subclinical patients of ischemic heart disease by means of, and I personally believe in this, calcium scoring is a very good tool to assess your patient's risk and decide about primary or secondary prevention. This CT angio is used for I think it's misused in symptomatic patient for coronary angiography. It's actually a risk predictor in low risk patients. A very good tool to pick your patients at subclinical level. And there are other ones as well inflammatory diseases, post-menopause. So a lot of additional things you have to add on when you are picking risk of your patient for having atherosclerotic cardiovascular disease to decide about use of aspirin in that particular patient. How do we use these findings? Low risk, don't offer aspirin. Medium to high risk, then discuss the pros and cons of aspirin use with patient preference to decide what to do. And in very high risk, recommended aspirin. So still in primary prevention, it's not completely out altogether. In high risk, it's indicated. Medium risk, you have to weigh risk and benefit, discuss pros and cons with your patient, but don't use in low risk patient. This is some guidance, and we'll go through these, just brief summary of these trials which created controversies. Aspirin, healthy old age. और ओल्ड एज अभी आप देखिएगा कि कितनी ओल्ड एज है. अराइव वॉज मिडल एज नॉन डायबिटिक्स and ascend young diabetics. And remember, these all patients who were really given placebo and aspirin, the rest of the risk was very well controlled. So again, you can't apply these patients to our population where nobody even knows his sugar, what's the level of sugar and hemoglobin A1C is. So you have to contemplate in each individual patients about his risk of having disease, not just applying study finding to everyone. Certainly, वो वाला criteria तो नहीं होगा कि हर 40 साल से ऊपर का आदमी aspirin ले. That is again a wrong strategy because you have harms with aspirin, GI bleed and other issues. So you have to pick your patient as an individual basis, considering risk and benefits. ये देखें, aspirin में जो age है in greater than 70 years. अभी तो ये तो हमारे यहाँ बेचारे पता नहीं होते भी हैं नहीं होते. इस्केमिक हार्ट डिजीज़ के रिलेशन में हमारा डिजीज़ अब 35 से शुरू हो रही है, तो इनमें प्राइमरी प्रिवेंशन तो वैसे ही कुछ बचता नहीं है. देन यू हैव अराइव मल्टीपल रिस्क फैक्टर्स, एज अगेन ग्रेटर देन 55, ग्रेटर देन 60, जिसको ये मिडिल एज कह रहे हैं अपने हिसाब से. एंड ऑल दोज रिस्क फैक्टर्स आर वेल कंट्रोल्ड. तीसरा ग्रुप वो था जो relatively young था with type 1 and type 2 diabetes, but well controlled diabetes with statin as well, taking all the things together to prevent cardiovascular disease. But all these three trials shown no additional benefit of aspirin in preventing cardiovascular disease. But in conclusion, the latest 2022, again, it's not out altogether. Age 40 to 59, with a 10% of greater 10-year cardiovascular risk, the decision to initiate low-dose aspirin use for primary prevention of CVD in adult of that, again, according to risk and benefit, but what they are suggesting that against low-dose aspirin in prevention of CVD in adults above 60 years. Old age with low risk, completely out. But middle age, with intermediate to high risk, yes, aspirin is there, integrating risk and benefit. This is 2019 ACC. Again, almost similar things. Aspirin might be considered in selected higher atherosclerotic cardiovascular risk, 40 to 70 years, who are not at increased risk of bleeding. Should not be administered on routine basis for primary prevention among adults greater than 70 years. बहुत ओल्ड एज लोगों में सिर्फ इस वजह से कि ओल्ड एज हैं देना ये भी गलत है. लो डोज एस्पिरिन शुड नॉट बी एडमिनिस्टर्ड फॉर प्राइमरी प्रिवेंशन अमंग अडल्ट्स एट एनी एज हु आर एट इंक्रीज रिस्क ऑफ ब्लीडिंग. सो इट्स ऑल depends again on integrating risk and benefit. Then again I am considering this fact that this disease has two phases. And atherosclerosis is completely subclinical phase. So you have to pick a right person to get benefit out of this aspirin strategy, that you contemplate that yes, this patient can have a bed of atherosclerosis sitting there without event. This patient need aspirin. That you have to pick with all these characteristics. So pick your patient at phase of atherosclerosis by means of other modalities or his risk status or even calcium scoring or other. And I think if he's at low risk of bleeding, he should be on aspirin even without events. So in conclusion, I would say present evidence create controversy about use of aspirin in primary prevention, but still it has given some guidance to you that moderate to high risk primary prevention with low risk of bleeding should be on aspirin. Rest we'll try to get the input from the experts regarding that should that evidence which is there be applied to low and intermediate risk of every patient irrespective of risk status or not, or there some more arena to use aspirin. That I'm leaving it to the experts. Thank you very much for your patience listening.